started. Welcome, good morning. We have lots of people in the auditorium. We've got another 1,500 people online to listen to Jeff Healey for this hybrid event. Just remember, for those in the room, if you want to ask a question, you have to go to the microphone. For those joining online, submit your questions in the Q&A feature. So I'm very pleased to announce Jeff. Jeff is an old friend of the Heart Institute. He did his cardiology training here in the previous century, not this century. I think, was that? Previous millennium, even more. So he's a cardiologist. Most importantly, he's an electrophysiologist. He's professor of medicine. He's the Yusuf Chair and Director of Cardiology at McMaster University. He's a clinical trialist. He's got 6 first author in New England Journal and Lancet papers to his name, and he's still relatively young. He was the lead author of the Artesia trial, and he's going to talk to us a bit about the Artesia trial this morning. Perhaps most importantly, he's the director of the cardiac sarcoidosis clinic at McMaster Clinic as well. So, Dr. Healey.
Thanks, David, for the introduction. It's always an easy decision to say yes to a visit here. It's a great institute. You should all be proud of it. And the real pride is the people. And that hasn't changed since I was here 25 plus years ago. You do a great job of attracting great people, and it shows on the smiles. So I'm going to talk about 2 things. So this is one of those 2-for-1 talks, but we'll try to weave a thread through it that makes sense. So atrial fibrillation, where are we today? We've really taken a bite out of things like stroke risk with anticoagulation. We've gotten better with AFib ablation, but our patients with atrial fibrillation still have substantial morbidity and mortality. So what do? We're always looking to improve patient symptoms, and we're looking to reduce bad outcomes. Stroke, still there, but heart failure is definitely the bad outcome for many patients. But we've gotten a better understanding of how this entity relates to these outcomes. And it's really, you can conceptualize it as a 2-axis entity. So on one axis is the burden of atrial fibrillation. How much arrhythmia is that patient having? And you show there on the y-axis. On the X, you're dealing with the risk factors because, of course, in North America and indeed most of the world, atrial fibrillation is a disease of getting older and having cardiovascular risk factors: hypertension, diabetes, obesity, alcohol intake, smoking. And these are directly and indirectly associated with the bad outcomes that happen. So where's the state of the art here? So if you look up at high burden patients with generally lower risk, these are the patients that often end up in our EP lab and get ablated. And you can see a collection of ablation trials there. There is one anticoagulation trial that Lena Rivard at Montreal Heart just presented, looking at trying to improve cognition in that higher burden but lower risk group. In the bottom left, you've got mostly the worried well. They're patients with very little burden, very little disease. And these are the patients that are flooding our clinics right now, picked up with consumer-facing devices. So they got an Apple Watch for Christmas. They're 40 years old. They don't have any risk factors. They've done 10,000 electrograms, and one of them might show atrial fibrillation. So what to do there? So that's really the bottom left is where we're talking about screening, right, for lifestyle intervention, and that's really the focus down there. But I'm going to focus on the right side, so the high cardiovascular risk, right? I'm a trialist. You want to study people who have a lot of risk of bad things happening, so you go to the higher risk edge of this pyramid. High burden, high risk. We're going to focus here on one thing, which is stroke prevention with our LEOS program. And that's the idea, a new concept of combination therapy, right? So anticoagulation plus mechanical intervention for high-risk individuals. And then in the high-risk but low-burden group, we're going to talk about subclinical atrial fibrillation and the Artesia program of pacemakers. So that's a long slide to try and make sense of what's going to come here in the next little while. So I started looking into this shortly after I left Ottawa around 2000. This is pacemaker-detected atrial fibrillation. We saw it all the time. Back in those days, we just had warfarin. Nobody treated it. Then 9 years later, we had the first DOAC, dabigatran, and then everybody wanted to treat every single episode, no matter how brief. And we've kind of ping-ponged around, but we're now here at a time where we have some evidence to kind of guide how we should manage it. So first of all, it's very common, right? If you look in pacemaker patients, about 1 in 3 will develop this over 2 to 3 years of follow-up. And a very similar number if you implant loop recorders in patients without pacemakers will have the same thing. And, the question is this really a disease, or is this like gray hair and wrinkles? Is this just something that happens and it really doesn't matter that much? We show that it is associated with the risk of stroke, but that risk is lower than what we're used to with clinical atrial fibrillation. And of course, since anticoagulation is still associated with bleeding, you have to make a risk-benefit calculation. So that sets the stage for this. It's been an interesting journey, and I'll show you what I've learned, because in my head, it makes a lot more sense now. So those were the ASSERT data. That's 12, 13 years ago, where we took pacemaker patients. Nobody had atrial fibrillation. Everybody was over 65 and had a history of hypertension. And those that had little bits of atrial fibrillation lasting minutes to hours over 2.5 years of constant monitoring. So really low burden. And just to start putting some numbers in there, this is like 0.01 to 0.1% of their time in atrial fibrillation. It's really small. And you can see their risk does go up. It's about a 2.5-fold risk increase, relative risk increase for stroke. But the absolute risk there is only 1.69% per year. So it's low, right? If you compare that to the orange bars, these are patients with clinical atrial fibrillation, you can see the white, which is the pacemaker detected stuff, is lower risk. And we knew this 12, 14 years ago, that this was low risk entity. So you couldn't just call it AFib and move on. We had to do some work because, of course, the converse was this, right? Even with DOACs, easier to use, safer. But, you look at the top right corner of that graph and you can see 2+% of people have a major bleed each year. So, and that's a relatively young population, average age of 70 in Aristotle. If you look in the subclinical pacemaker population, the average age is about 5 to 10 years older. So you can see on the right, when you start getting up into the mid-70s, the bleeding risk takes off quite a bit. And just, again, keep some short-term memory of these numbers. So 2% major bleeding overall. And if you look at the 75 age group, this gets up into the 2 to 3% range. So think about those numbers when we start showing the data from Artesia. So 2020, a lot of gaps on the guidelines. We also had this grid type approach where you had CHA2DS2-VASc on one axis and burden on the other axis, looking at the amount of atrial fibrillation with recommendations to treat if stroke risk factors got high and burden was high, and to ignore if the opposite was true. And again, you get a little preview here. That might not be too far off what we're recommending after the fact, but that was state of the art. So Artesia, we started a number of years ago. I think David and I we were out in Whistler, I think, David. We might have even been on a ski lift when we started talking about this trial. And David's like, man, I don't know if we can enroll to that. No one's going to want to get treated because, again, it was warfarin days. Patients with high risk, CHA2DS2-VASc on average about 4. You can see the individual inclusion there on the left. They were randomized, double-blind, double-dummy to apixaban at the usual AFib dose, or they received aspirin 81 milligrams a day. That seems out of place to anybody under 40 here, but back in the day, aspirin was generally used for low-risk patients with atrial fibrillation. And about 60% of these patients also had other indications for antiplatelet therapy. They had coronary disease, they had history of bypass, history of stroke, and for those reasons, aspirin we chose as our control. Outcome was stroke or embolism, very simple, and we used the same bleeding definition that I showed you for Aristotle just a few slides earlier. So what did it show? It shows that it works. Apixaban does reduce the stroke risk by about 37%. Those numbers are still small though, so it's a significant difference. The p-value is highly significant, many zeros, but you're going from an average of 1.24% per year to 0.78. Okay, so that's probably reaching the edge of where the anticoagulation is useful. And in fact, overall, many would say, hey, just us treating everybody there, not so sure. But when you look at clinical trials, there's a difference. If you take a trial that is neutral, shows no effect, and you start drilling into it to try and find that magic subgroup that benefits, that usually leads you astray. And that's not really going to get you anything useful. If you take a trial that overall is positive and you start drilling into it to see where there is benefit and what groups of patients that don't benefit, that can be more useful, particularly if you can replicate that in another data set, which I show you very soon is something we've done. But 1.2, that's a stroke rate per year. If you look at it here, you can see that the strokes, about 40% of the strokes are bad strokes. So the modified Rankin score of 3 to 6. 6 means you're dead. 4 or 5 means you're severely incapacitated long-term. And so, I was a little bit surprised that so many of the strokes were bad strokes. Down there on the bleeding side, look at the apixaban bleed rates. These are ISTH, so the same as that Aristotle rate, which was about 2.1, 2.2. Here it's 1.5, and this population is about 9 years older. And so how do we get away with that? And we're unpacking that. Deb Siegel, I'm not sure if she's here, is doing some work with us. She was one of our lead adjudicators for bleeding, hematologist here in Ottawa, and she's unpacking that. Part of the story may just be the secular trend in using less combination antiplatelets on top of oral anticoagulants, because of course we did allow open label antiplatelet therapy. So those are the relative numbers. So you got roughly similar rates of bleeding and stroke. So what is someone to do? The strokes, about 40% of them are bad, so permanently disabling. The bleeds, on the other hand, about 80% to 90% of them walk away, treated with conservative measures or supportive things like crystalloid or transfusion. Death and fatal bleeding was not different between the two groups, and the need to intervene, do an endoscopy, take a person to surgery, was similar between the two groups as well. So those really catastrophic bleeds seem to be the same. The excess were in the ones that required supportive care or conservative management. So as I said, that's the take home. So you've got an effect. It's clear that it reduces stroke. You've got an offsetting hazard of bleeding in roughly equal measure. But we do have a second study, right? When this is NOAA, it's very similar design, used edoxaban. The control arm was a combination of both aspirin or placebo, depending on the patient. And you can see, the outcomes are importantly different, right? So we looked at a very focused outcome, stroke or embolism. They looked at a stroke or embolism, embolism meaning things like MI or pulmonary embolism, which normally wouldn't be in the mix for an AFib trial, but they also looked at cardiovascular death. And of course, in AFib, almost all cardiovascular deaths are heart failure or sudden death. And so we would not expect those to move so much with anticoagulation therapy. So those are the big differences and points. So NOAA did allow some patients to be on placebo as the control, and they looked at an outcome which incorporated many different things. But we did publish this paper very shortly after our presentation in conjunction with the NOAA group, where we looked at the effect on stroke. And you can see on the top set of graphs, the outcome looks very similar, and in fact, statistically is the same outcome. So the pooled estimate there is about a 1/3 reduction in stroke. And you can just see that NOAA has the wider confidence intervals because it has far fewer events, stopped early, and has about 1/3 to half the number of events of artesia, but the effects are consistent. If you look at the big outcome, the NOAA outcome, so to speak, where you roll everything up together, including cardiovascular death, this is about a 15% reduction, which just makes significance. But again, the message here is it's a consistent treatment effect. Where there is some variability here, as you would expect, is bleeding, right? So about half of their patients in the control arm were on placebo. Obviously, that is going to accentuate the bleeding when you're comparing an anticoagulant against nothing. There's going to be more of a contrast there because aspirin does cause a significant amount of bleeding in older people, as we all know. So that is, you can see this here with the heterogeneity because those two points are very separate, but fatal bleeding was uncommon and similar in both groups. So that's the first lesson from the two trials. How do you reconcile two trials that seem to have opposite results? They actually show the same result, but it's a matter of power and number of events. And when you compare this, and we're going to do patient level meta-analysis, we're actually starting on it now with all the data from both trials together. I think you can see that the results are actually more similar than they are different. So where to treat, right? What do you do? Like, do you treat for a 37% reduction in stroke if the baseline risk is between 1% and 2%? That's a tough spot, right? The ACC/AHA guidelines would put that in the yellow box, 1% to 2%, saying, maybe yes, maybe no, up to you. So where do we look to find benefit? And again, I'm going to show you two graphs here, and they are, need to be interpreted correctly. So the first graph here is a relative effect. And what we show is there's no real difference, even though it looks like the CHA2DS2-VASc greater than 4 there have a greater relative risk reduction. Nominally they do, but statistically, the effect is the same. But remember this, the overall effect is not no effect. The overall effect is there's a 37% reduction in stroke. So that doesn't really help you. But what we're really trying to drill into is what's the absolute risk of stroke. And this is what we're going to show on the right. And you can see here that as you go up in the CHA2DS2-VASc scores, obviously the baseline risk of the patient goes higher. And for these interactions, anything less than about 0.1 is considered significant. And you can see that there is a significant increase in the bang for your buck, so to speak, the absolute reduction in stroke that one gets as you go into the high-risk group of CHA2DS2-VASc greater than 4. And with the bleeding, it's not so clear. It's kind of an equal effect across the deck. And if you look at this in more human terms here, using NNTs and NNHs, you can see for the bottom row there, CHA2DS2-VASc greater than 4, there's about 27% of the people in the trial. Over the 3.5 years, you prevent 3.95 strokes in the anticoagulation arm. So that's an NNT over 3.5 years of 25 to prevent a stroke. So you have to treat 25 people for 3.5 years to prevent a stroke in that group. In contrast, the number needed to harm is slightly larger. It's about double the risk, the benefit of stroke reduction. So we felt that that group is a pretty good group in whom to treat because they have an annual stroke risk of greater than 2% per year, which puts them in the box, the to treat box in the AHA guidelines. On the other hand, the complete opposite is true when the CHA2DS2-VASc is less than 4. So for these patients with very low burden atrial fibrillation, the NNT for that 39% of people is about 2,500 for 3.5 years. That's obviously a non-starter, whereas the number needed to harm is there and is substantial. For the equal to 4, that's a mixed bag. It really depends what your 4 is. Is it a stroke and coronary disease, or is it hypertension, female sex, and older age? And so that's a bit of a wash. In general, the NNTs suggest to treat, but I think that's a little bit of a superficial interpretation. But I think over 4 for sure, equal 4 selectively, under 4 probably not at all for treatment. Here's just the data on the prior stroke group. People in the trial wouldn't enroll patients very commonly with prior stroke. So in all of our observational data, about 15 to 20% of people in those cohorts had a history of stroke, yet only 8% or whatever the number is, 10% here got in with a history of stroke. And that's because our referring doctors didn't feel it was ethical to randomize in some cases. If there was a stroke, they saw 22 minutes of AFib, they said it must be treated. But some people were enrolled, about 300, and perhaps the people that refused to enroll were correct because there's the Kaplan-Meier curve for the prior stroke group. So we fussed. There's a lot of debate now over if you find little bits of AFib on a loop monitor after an ischemic stroke, what do you do about it? Here are data, randomized blinded data on 346 patients. And you can see there, there's a substantial 60% reduction in stroke. It's the inverse to the overall effect. About 60% of these strokes are ranked 3 to 6. So big strokes for the most part. And then, the absolute risk reduction is high with a 3.5-year NNT of 16 people. So this, is just going to come out in the next couple of days in an interesting journal, but the interaction is there. And you can see in that prior stroke group, the absolute benefit is high because, again, at 3 years, you can see their stroke risk on aspirin is north of 10% at 3 years. So it's a very high risk group. That's like over 3% per year stroke risk, and it definitely goes down. So again, the NOAA group put out a small paper based on 11 events, said there's no effect. You can see it there, the bottom whisker in this plot. You can see the Artesia event on the top. And again, it nets out to somewhere around a 60% reduction. But those are ischemic strokes, not all-cause stroke. That's why the numbers are slightly different. But you can see the relative numbers. You know, we had, and they're still small, right? We had 25 events in Artesia, NOAA had 11. So it's about 2.5 times bigger. But again, the message here is the trials are more alike than they are different when you drill into the actual outcomes. So for stroke patients, I'm really convinced if you find atrial fibrillation in this context, it's probably something. And we can get to that in the question, this ongoing debate over AFDAS and things like this, but this is, I think, pretty clear. And the last subgroup we did, and this was led by the NOAA group, was looking at patients who had vascular disease, carotid vascular disease, peripheral vascular disease, coronary disease. The logic here was it was a more apples to apples comparison of the two trials, right? You know, because if you have any of those vascular disease states, you're going to be on antiplatelets. So there's no question about, you know, whether placebo is a better control, right? Like, you know, are you treating a post-MI patient with placebo or are you treating them with antiplatelet therapy? That's pretty easy. And you can see here, they also have a different risk profile, right? So they're going to have a different collection of factors, you know, for the CHADs, as I said. So, you know, they're going to have more history of stroke, more history of vascular disease. And you can see, again, here, the pooled estimate on stroke reduction on the top. If you have a history of vascular disease, it was about a 45% reduction in stroke. Significant. If you didn't, it was less obvious. Okay, so that's what I'm talking about when I'm talking about the fours. If it's a 4 with a kind of vascular profile, you can see here the effect on stroke reduction appears more. Caution you though, that is not, the interaction is not statistically significant, but you know, those are the nominal data. What is relevant here is the bleeding, right? So there's no real heterogeneity between the two studies when it comes to bleeding. There's no bleeding difference between edoxaban and apixaban, right? The difference was what was the control group. And again, in the top, the control group is nearly 100% antiplatelet therapy. So, you know, there's not this big contrast between the two trials because everyone in the control for both arms is getting an antiplatelet agent. And whereas the no vascular disease at the bottom, you can see those whiskers don't really line up very well because the gap between the two treatment arms for NOAA is much higher. So this is, you know, so these are the things. So high CHADS VAS greater than 4, equal to 4 maybe if you're in this vascular disease group. And if you have a history of stroke, those would be my recommendations for who should get treated. The rest of the patients should get monitored, right? About 8 to 10% of these patients will progress to manifest AFib over each year. And so, you know, we do have fancy tools on our pacemakers to follow patients to look for the emergence of arrhythmia because it's not just a fire and forget. You have to follow patients along if you choose not to treat them because about 1 in 10 will progress each year and you have to be aware of that. So what doesn't predict risk-benefit considerations? Let's not spend too much time on this, but age is a complete wash. Okay, so it's not, the idea of younger people, older people, it doesn't matter. The effect is impervious to the age. Those interaction p-values are about as negative as one can get. That's a little bit surprising. But what's very surprising is this whole issue of burden. So we looked at this. The stroke risk in the control arm of our trial, it didn't matter. You know, we enrolled patients with 6 minutes to 24 hours of AFib. That was the range that we enrolled. Just in the placebo or aspirin event rates, there was no difference at all, 0. And one looks at the treatment effect, you know, how good does an anticoagulant work? To the left favors apixaban, to the right favors aspirin. It almost looks inverted. That if you have short episodes, you benefit more from an anticoagulant. And if you have long episodes, you don't. Now, this is intention to treat. What's happening here is people with long episodes are progressing. They're getting started on open label treatment, stopping study drug. And so, you know, if over 6 hours, if 20% of those patients are progressing each year, you're ending up with a group that's largely treated with open label therapy and is off study drugs. So that is the post-mortem on that analysis, but absolutely no effective burden. And how does that make sense? Because we know burden matters, right, at a big scale. But I think what the decision here is when you're comparing those episodes, again, you're going from about 0.01% burden to 0.1% burden. That probably matters a lot less than going from 0.1 to 10%. And so I think that is, again, this is still being analyzed, and we'll look at it further with the meta-analysis. But, clinical risk factors seem to win this first one. They trumped episode duration, at least amongst the patients who we recruited in the trial. Overall, I think there's probably 40 to 50% of these patients that should be treated up front. Majority of patients don't require treatment, but require careful surveillance because they will go on. And if you want to look at risk factors, CHADS VAS greater than 4, vascular disease, and prior stroke would give you a good group of patients with whom you can treat. Very quickly, screening. This is my greatest failure as a researcher. I had a clinic here with Martin Green a number of years ago, and a patient came in. This is like 25, 30 years ago. Patient came in and said, "Doc, I think I have AFib." We're like, "Okay, tell me." And he goes, "Well, my brother has AFib. I started having these skipped heartbeats." And so I went into my garage, and this guy was an engineer, and I built an electrocardiograph. And he brought in this green plotter paper with ECG. He said, "This is the standardization for time and voltage." And he made his own ECG. And this was the first time I'd ever seen a consumer facing product pick up atrial fibrillation. It's probably in the basement somewhere here or offsite. So if anyone has a summer student that wants to look for that, I'm sure it's on Marty's chart. But we have all sorts of tools now, right? What to do? U.S. Preventative Services Task Force says, don't know. Not enough information to decide whether we're screening or not. Part of the challenge is, screening is a very tough game, right? Like when you're screening big swaths of the population, your potential for cost and harm and worry and all this stuff is very high. And, they don't let too many things through the Preventative Services Task Force, right? In terms of, and for good reason. They're very thoughtful individuals. We've worked a lot with them. But the big problem is you get into this. Now, from a clinical trial perspective, the Apple Heart Study was brilliant. Like 500,000 people enrolled themselves, did their own consent, and entered their own data. No study team, right? And they got the thing. I mean, it was an incredible display of how you might run a modern trial, right? Like that cost them nothing for 500,000 recruits, right? The problem was who signed up. It wasn't Dave Burney and Jeff Healey. It was young fit people, right? It was Rebecca and her friends. But it's so the rate of false positives was very high, and you probably wouldn't expect to move the needle on stroke screening a bunch of predominantly wealthy people that could afford a watch and motivated health conscious people who decided to self-enroll. Like that's the exact opposite of a group you're likely to help. And of course, that was part of the issue. But it did raise a certain big point. And the big point in screening is intensity. Do you take a device and do this with your thumbs once or twice a day? Or do you implant a device under the skin to monitor every heartbeat for the next 4 years? That is the discussion we just had with our T's here, right? Do you have a pacemaker that monitors everything, or do you turn up to the ER with an ECG? Because we've now shown that the prognosis and the management of those two types of atrial fibrillation, even though they look the same, are completely different, right? So if you're getting into screening, we have to consider intensity of screening, and we have to consider who we're screening. Are we screening healthy 40-year-olds that worry a lot? Are we screening people with true bill, people in the vascular prevention clinic? Are we screening those individuals? And these are good concepts because, burden, we've talked about burden for a long time, right? So, I used to cath with Marino. He taught me how to put catheters. The joke was, you go down in the cath lab, he'd give you the needle. We did femoral back then, and you'd stick the needle in the groin. And if you hit the artery, you're a cath fellow. If you hit the vein, you're an EP fellow. It was like the sorting needle. So I hit the vein more often than not. He goes, "There's this really nice guy down the hall named Martin Green. I'd like you to go see him." But we think about that in the cath lab too, right? Like if you go in and do an angiogram and you see a few 20 and 30% stenoses, you're going to treat risk factors. Are you going to send them for 3-vessel bypass? I hope not, right? Because the burden of disease just isn't there, right? but the risk factors are always present. And I think we're really seeing, it's sacrilegious to say, but the EP group is learning from the Catholic group in terms of the mindset, because we're going to address risk factors. We didn't do risk factor treatment 10, 15 years ago in AFib. We ought to, because it's very important. We didn't consider burden of disease when selecting treatments, but we're now doing it. And so, it comes full circle. I told you that between 0.01 and 0.1% burden, or even 1% burden, there's not much going on in terms of a graded risk, depending on burden. Same is not true for the other end. And this is a really cool paper we did 10 years ago. And what we did is we adjusted we took a bunch of patients treated with only aspirin. It's about 6,500 patients from 2 of our clinical trials. And we adjusted for every predictor of stroke. And then we looked at the type of AFib, permanent, paroxysmal, persistent. And what you can see is if you're in permanent AFib, your risk of having a stroke is double what it is in paroxysmal AFib, correcting for everything. And, so at that level, again, you're going from paroxysm, which might be 1 to 5, maybe a little bit higher in some cases, but median burden, to 100% burden, right? And it does matter. And look at the rates. Paroxysmal, 2.1% per year. So it's just into the treat zone of the AHA. Permanent, double, 4.2. Okay, so that's so there is this graded level of risk, but it's not a straight line, right? We go across, there may be very little variation at the low end, somewhere in the middle, it gets bigger. And then when you get up to being an AFib all of the time, the risk really does jump up substantially. So, I always worry about the CHA2DS2-VASc 0 patient who comes in with permanent AFib. They've been in it for years. They may be a little bit obese. It's always a relative of someone in the hospital. And over 25-year career, you see those people come in with strokes. I've seen 2 or 3 of those people, actually only 2. And then I started anticoagulating them all or putting them in Lena's Brain AF trial. Because, if you're in AFib all the time as a 40-year-old, that's not good. And those people do have strokes. We're going to get some clarity on screening. This is a big table just to show that there are many screening groups. We chair an international collaboration on screening. Many randomized trials will have a pooled patient-level data set of over 320,000 patients in randomized trials. We've actually got about half of it already assembled at a database in Copenhagen. We have published one little snapshot of it, suggests that screening is associated with about an 8% reduction in stroke. That seems piddly, but for screening studies, we never get 30 or 40% reduction. You're getting 5 to 10% reduction if screening works, right? So there is some hope, but again, these are largely trials using insensitive tools like handhelds and screening older, sicker populations, right? So I think, again, it's this axis of burden of AFib versus underlying cardiovascular risk. So what are we going to do at the top end? I've talked a lot about the bottom end, which is low burden pacemaker device detected atrial fibrillation. Give you a little hint of what's coming down the road for screening. What about those patients who unfortunately are in AFib all the time? What can we do about that? And I'll just give a little Canadian content here to this fellow. You can read, I guess, that's C. Miller Fisher. He's a Canadian who went down and founded didn't found the neurology group, but really took it forward at Harvard. And he was really the first guy that really reported, ironically, in the Canadian Medical Association Journal about the association between left atrial appendage thrombus and stroke. And so that's 1953. And if you go to Harvard to give rounds, C. Miller Fisher is a big deal there. And they're like, oh, C. Miller Fisher from Ontario, right? And that is him. And that's what we're talking about. My late colleague and mentor, Stu Connolly, is another such fellow. He really did more to advance atrial fibrillation on multiple fronts than probably anybody else. He was actually a pretty cool guy. He could wear a tuxedo, but he was still into his mid-70s, getting on the podium at World Championships for the Ironman. And so, there's a serious beast of a guy. Like, you go out and bike with him, he could pull 35 to 40 kilometers an hour all day. Just incredible athlete. We cooked up a series of trials when I first came from Ottawa to Hamilton, and this was the LAOS program. And we're at the 4th trial. Actually, there's 7 of them right now. And the premise is this. About a quarter of patients who we see with atrial fibrillation have non-paroxysmal AFib and a CHA2DS2-VASc score of at least 4. If they're anticoagulated in clinical trials and everything goes well, they still have a stroke risk remaining of about 10% over 5 years. So a high residual risk. Residual risk is a key point. And we think that intervening on the left atrial appendage by having Moreno and friends put in Watchman's can reduce this risk by 40%. And that's bang for your buck, right? So we argued about, is it worth it in subclinical AFib because the event rates are low. I'll show you data here that these patients are at very high risk where, intervention might work. And, why? Because of course, people have limitations. The drugs don't work perfectly, even if you take them perfectly, but people rarely take their drugs every day. And if you're on a short-acting direct anticoagulant, this can be a problem. Patients bleed, they get in car crashes, they have scopes, they have surgery, and they're taking them off and on all the time. About 25% of everyone on an anticoagulant in the first 2 years comes off it for a surgery or a procedure. And then the long-term persistence data are still fairly humbling. These are US data. This is over 1 million patients treated with anticoagulants. You can see by 2 years with warfarin, about half the people are off at 2 years, and about a third of the patients are off on DOACs by 2 years. So when you do a one and done consult here in the clinic, you say, yeah, you need AFib treated with anticoagulant, your CHA2DS2-VASc is high, here you go. This patient's going to do well. See them in 3 years, see what they're doing. It's hard to argue with data on 1.25 million patients treated for AFib with anticoagulants. That's a big data set. But here's even better data. These are Danish data, right? Everybody in the country of Denmark is born into a registry trial. It's an opt-out, not an opt-in. And so they have 100% capture of all their follow-up. And you can see there, 50% are off within 2 to 3 years. So it's tough. And this is the issue. What does that translate into? This is one of my former fellows who published this just a few weeks ago. This is based on the combined registry, where it's again a patient-level meta-analysis of all the DOAC trials mixed into one. And you can see there for non-paroxysmal AFib with a CHA2DS2-VASc greater than or equal to 4, the residual risk of stroke there is about 4% at 2 years. So it's high. And in the ORBIT registry, which is another big observational study, again, that same number keeps popping out, 2% at 2% per year for CHA2DS2-VASc greater than or equal to 4. So that is, again, you can look at it 2% per year and say that's small, or you can say over the next 5 years, what's going to happen? Because as I've shown you here, anticoagulation persistence just gets worse over time. The beauty of a mechanical intervention like atrial appendectomy or Watchman is you just have to do it once, right? Appendages seldom grow back. I've never seen it, but maybe salamanders' appendages grow back. But that's the value proposition. And then finally, like in artesia, what happens with patients with prior stroke? This is a mind bender here. If you have a stroke, if you have atrial fibrillation, you come in today with a stroke, and you break them into 2 groups. Were you prescribed, not taking, but were you prescribed an anticoagulant at the time of your stroke? If the answer is no, you're in the blue line, which means in the next 2 years, you've got a 6% chance of having another stroke in the next 2 years. However, if you were on an anticoagulant when you came in, or at least prescribed and not taking, that risk is about 12% in the next 2 years. Okay, so we're not monkeying around with 1.5% stroke here. This is a 2 to 4% per year. Actually, it's higher. It's a 3 to 5% per year stroke risk. Okay, so this is multiples of where we draw the line for doing something about it. And this is on anticoagulants, right? All these patients are on anticoagulants. And so it's a humbling thing. So if you have a breakthrough stroke, or even if you don't, you just have AFib and you come out with a stroke, it's a very high predictor of recurrent events. So why do we think we can do something? Again, the next concept, first concept is residual risk. To understand that anticoagulation is not perfect. The second concept, which we also stole from the cath lab, is combination medical mechanical, right? We put in stents and prescribe statins. That's normal behavior, right? So why wouldn't we consider for high risk people prescribing anticoagulants and doing something mechanical? Well, here's why we're going to consider it, because this is the large LEOS 3 trial. This, again, started when I moved to Hamilton in 2001. Big, simple trial, nearly 5,000 patients coming for heart surgery with atrial fibrillation. Half the patients got an atrial appendectomy, half did not, and followed simply for the outcome of stroke and embolism. You can see what happened. There's a big win for taking off the appendage. These are the first data that show that doing anything to the atrial appendage reduces ischemic stroke. Never been shown before. This trial had 22 independent sources of funding, not a nickel from industry, believe it or not. We got free Ethicon surgical bowel staplers for part 1 and part 2, because that's what we used to take off the appendage. It was really kind of a triumph of public funding. You can see the Kaplan-Meier curves. I rarely say this, but they do come apart the further you go. Okay, again, why? People stop anticoagulation over time. Appendages don't grow back. And so that benefit blows out the further you go in follow-up. It's accentuated even here when we do this, what's called a landmark analysis. First 30 days after open heart surgery, people can have a stroke for a variety of reasons, right? A little bit of junk up in a carotid or some air coming out of the heart. There's a lot of things that can make a person stroke. If you separate that first 30 days of perioperative stroke, where there is trend to benefit, we're not talking about a 35% reduction in stroke in the long term. We're talking about a 42% reduction in stroke. So it's actually, and that's just one landmark analysis, but we think we can prevent somewhere between 40 and 50% of strokes when we take off the appendage at the time of heart surgery. So this is now standard practice in many places, if not most places, that if you have AFib and you're coming for surgery, you get it off. We have a large trial that's really about 12 to 14 months ahead of schedule, where we're taking high-risk patients who don't yet have AFib, but they have big atria or PACs or neuropeptides that are off the charts, and we're randomizing them to take it off or not, because it's a 5-minute, $5 intervention when you're doing heart surgery to take the atrial appendage off with scissors and sutures. So it's actively ongoing. Ottawa Heart's part of it. But this effect in LEOS 3 surgical trial, it really didn't matter if the patients were taking anticoagulants or not taking. The effect was consistent across those groups, whether you're on anticoagulants all the time, none of the time, or some of the time. And so that really gives us, we can't take patients for open heart surgery who are not coming for it already, but, could you use the Watchman device or similar devices that we're already using in clinical practice as a combination tool in patients who have high risk, like I just identified. So that's the premise for LEOS 4. 4,000 patients. Everybody gets anticoagulated. Could be with warfarin, could be with DOAC. Doesn't matter. We're allowing all sorts of folks, so mechanical mitral valve, no problem. The only thing we're excluding are things like patch closures of septal defects, just because we don't want any, horror shows with respect to Watchman implantation. And they're again followed for that simple outcome of stroke or embolism. The detailed criteria here, but again, it's non-paroxysmal AFib, CHA2DS2-VASc of at least 4, or they can have paroxysmal in the case that they've had a prior stroke or embolism. Because again, as I've shown you, that's a super high risk group independent of everything else. So that's what's ongoing. Marino is the hot ticket this week. The team's been very good with enrolling here in Ottawa. So thank you to the Marino and gang for that. Again, that's going to take us 2 years to enroll and another 2 years to follow up. But I think that will be an interesting study. I think there's a good chance it could be successful. You never know, right? But I think it's better than even odds that that's going to work based on, the LEOS 3 result, which is compelling. But I'm going to stop there and just say, again, we're looking at this atrial fibrillation in the context of risk factors on one side and burden of disease on the other side. I think for the subclinical pacemaker detected, which you might even extrapolate into screen detected atrial fibrillation, you're only going to treat about half the individuals. The rest need careful follow-up, but you're going to treat the half that have the highest stroke risk profile. For the high burden people, I think we may have a very different approach to how we manage them. Maybe with bundle branch pacing, AV node ablation may make a comeback. We'll see. But I think for the high risk stroke prevention, I think the paradigm of combination medical and mechanical therapy is being tested and is exciting, because I think there's a very good chance it could be successful. So thank you.
The reason that patients get pacemakers, they have sinus dysfunction, they have kidney block, they get pacing-induced cardiomyopathy. So is it the same disease device detected by, I mean, pacemaker ICD detected, as the AF detect on a 75-year-old child/4 with a reveal monitor?
Yeah, I think it's a good question, David, and I think you could even throw into the mix the post-stroke patient, because that might even be different. Now, my thinking's evolved a lot over 20 years on this. Initially, you'd say, okay, obviously, right? They have tachybrady syndrome, so of course they need a pacemaker because their sinus node doesn't work. They have AFib. That's special. Then we and others, the Reveal AF group and others, just put loop recorders in a bunch of similar 65 plus patients with vascular disease and found more or less exactly the same amount of atrial fibrillation. So then the conclusion was, hey, it's just age and risk factors, right? I think now with these large data sets, we're getting a little bit more nuanced. And as we have more studies and we study slightly different populations, you see some interest